um, for the very kind introduction. I really hope everybody can hear me. Yes? Okay. Um, I do apologize I cannot be there on site with all of you in Khon, but I'm very thankful for the technology that allows me to connect to all of you in this way. And I'm also very grateful to Professor Shriving as well as the organizing committee for extending this very kind invitation to me today. So I think in the introduction, it was mentioned that I work in Singapore, both as a geriatrician as well as a palliative care physician. So I have the unique opportunity today to be able to present to you an integrated perspective of caring for patients with dementia at the end of their lives. What I will do today is to discuss the barriers and the solutions to delivering high quality integrated geriatric palliative care and consider the components of a patient-centered model of care that all of us here, whichever healthcare setting that we are practicing in, will be able to implement. We have this opportunity today to consider the current state of access to palliative care for our patients living with dementia and consider how we can actually implement both basic as well as specialist palliative care principles and translate them into impactful outcomes for our patients. So I really think that we need to contextualize our discussion today by first understanding the global epidemic that we all know dementia to be. In spite of advances in the detection of dementia, as well as the advent of new disease-modifying medications, dementia unfortunately remains an incurable disease. It is progressive and it causes very significant cognitive as well as physical ability at the end of our patients' lives. Currently, we know that more than 50 million people throughout the world suffer with dementia, and this number of vulnerable population of individuals will increase to involve as many as 132 million people by 2050, which is really not too far in the distant future. The cost of caring for patients across the spectrum of this illness is really tremendous, but none as great as at the individual level and at the familial level, where the costs are really incalculable. Now, if I can draw your attention to the right side of this slide, which shows you the world map, and you can see that the prevalence of dementia is currently greatest where we live in the Asia Pacific region. And for the very singular reason that we have the fastest aging population throughout the world. This is a pie chart as well as a histogram that shows you the number of patients forecasted to be suffering with dementia in the US between 2020 to 2060. What it shows you in both of these diagrams is that there is a rising incidence of dementia with increasing age, a trend that is also reflected in Thailand and in Singapore with this study, this epidemiological study of dementia prevalence that was published first in 2015 in Singapore and then recently updated this year. It shows that using either the DSM criteria or the 1066 criteria, which is more sensitive to detect dementia in our part of the world, the incidence of dementia will rise with age. At about 60 years of age, the risk of developing dementia is about 10%. But as we grow older, the risk can be as many as 1 in 2 of us over the age of 85 years. So age is the single biggest non-modifiable risk factor for developing dementia. So what do these statistics mean for all of us here as a healthcare community? It means that we will be looking after an increasingly older and aging population of patients, many of whom will be suffering with dementia to some degree as a comorbidity, if not the life-limiting illness. So we as a community understand the functional and cognitive impact that dementia has for our patients as they transition through the different stages of this illness. Hence, many best practice advisories for dementia have advocated for the early integration of palliative care principles, not the late integration as what is currently happening, so that we can help our patients meet their evolving needs as they transition across the different phases of this illness, and we help them to live well even in the advanced stages of this illness. But these aspirations are lofty, given that non-cancer palliative care, particularly that for dementia, still trails far, far behind that for cancer palliative care. In 2013, when we started looking seriously at this subject in Singapore, we found that only 4% of patients in Singapore were referred for palliative care support who were suffering with dementia. And to this very day, it is less than 10%, which is incongruent with the number of patients in Singapore suffering with dementia, which currently numbers more than 100,000 individuals. Now, this was a recent editorial that was published in Palliative Medicine, one of the more eminent palliative medicine journals in the world. And this was published by some of the thought leaders in geriatric palliative care. They estimate that at any point during the dementia trajectory, at least 40% of patients, 40% of patients will need palliative care. So at less than 10% in Singapore, we as the rest of the world are still falling far short of actually integrating palliative care for our patients. We need to consider this discrepancy. Why are so few patients with dementia being referred to palliative care? Does our current practice reflect or imply that we think that they suffer less than patients with cancer as well as other end-stage organ diseases? Now, these are functional survival curves to the right of the slide that shows you the progression of patients suffering with cancer, with end-stage organ disease, as well as frailty and dementia. Now, what is common in all end-stage diseases, including that of dementia, is that patients experience functional decline, but in dementia, cognitive decline is quite significant to the point that our patients do die of complications in relation to dementia. They do suffer significantly, as many of us will also attest to. Yet, in spite of the degree of burden of suffering and the fact that they do die of these complications, which implies that dementia is a terminal illness, we continue to offer them differential care or different care in the hospital setting, as reflected in these following studies. Now, this was a study that was published some time ago in the United Kingdom. It was a retrospective chart review of patients who were admitted to a tertiary care unit in the United Kingdom, very much like what you have in Khon University, very much like what you have in my hospital in Tan Tock Seng. Now, what it showed was that patients with advanced cancer were less likely to receive palliative care support compared to patients who actually were of normal cognition. And even at the end of their lives, patients with dementia were less likely to receive palliative care interventions to alleviate their suffering compared to patients with normal cognition. These findings were also similarly echoed in nursing homes across the US in a study that was published slightly later. Now, this study compared patients who were suffering with dementia versus their counterparts with cancer in the last 4 months of their life. And they found that patients with dementia were less likely to have advanced care plans discussed. And even if these advanced care plans were discussed, it tended to veer towards the aggressive stance, meaning that these poor patients were more likely to undergo intensive care interventions in the ICU, such as CPR and even ventilatory support. Even though their prognosis was poor, because this was the last 4 months of life, these patients may still have received insertion or may have still had feeding tubes inserted in the last 4 months of life. They were more likely to undergo laboratory investigations in the last 30 days of their life, be restrained, and continue to receive intravenous drips or medications that did not appear to prolong their survival. Signs and symptoms that were more prevalent in patients with dementia included the presence of pressure ulcers, pneumonia or lung infections, fever, lung aspiration, and eating issues, including dysphagia. In a multivariate analysis of this data in the US nursing homes, they found that patients with dementia were also more likely to be prescribed psychotropic medication, which many of us here know is also associated with an increased risk of mortality. So I think I need to stop here and ask this very important question. What are some of the barriers that limit the integration of palliative care into dementia care in your practice? Now, this question was actually posed to more than 200 geriatricians or elderly care physicians in the Netherlands, based on the data that you saw that. Because the interventions that we're offering clearly are not extending our patients' lives, nor improving their quality of life. So this question was posed, and these were the most common themes raised by our colleagues in Europe. First, the most significant factor was the lack of understanding and awareness about palliative care. There is still a common misunderstanding that it is only end-of-life care, that it should only be applied to cancer, when all of us here know today, as with the theme of our conference, that it is not just meant for patients with cancer, but it is also meant for patients with dementia. It should be applied at the beginning of the diagnosis and not the end of dementia. So this, number one, was the major issue. There was a lack of understanding of how to identify symptoms in patients who can no longer speak for themselves when they are in the advanced stages of dementia. So many of our colleagues in this study shared the challenge of being able to identify symptoms and therefore implement palliative care in a timely manner. Now, this lack of awareness and knowledge around dementia care, as well as palliative care, was not only restricted to our colleagues working in elderly care medicine, but also to the interdisciplinary team members in the hospitals and in different healthcare settings. So you can imagine that the information that we share with our families, with our patients, is often conflicting and therefore leads to a lack of consensus between the medical teams and the families, so that there is often a lack of agreement about how best we should care for patients suffering with dementia. So we often default to more interventions and more care in the hospital, which we know may not be the best option. Last but not least is the fact that it is so hard to maintain staffing within hospitals, within the community in nursing homes, so much so that even when we do teach and we develop models, it might be very difficult to sustain these models as well. Now, I'm very intrigued by the fact that although these were findings that were shared with us with our colleagues from Europe, these are sentiments often shared with me from many of my colleagues, not only in Singapore, but many parts of the Asia-Pacific region where I do share our findings as well. So very oftentimes, our patients basically still move in this two-dimensional model of care, where they transition with particularly increased frequency from their homes or nursing homes into the hospital to receive the care we just spoke about. Intravenous drips, laboratory investigations, and they do this with particularly increased frequency in the last month of their lives. And unfortunately, many of them die in the hospitals, away from the loving presence of their families in their homes, or even in the care environment that they might have been most familiar in the nursing homes. And we have actually proven this in Singapore as well, in a study that we did examining the healthcare utilization of all end-stage illnesses, including cancer and dementia, which in this graph here is represented by the maroon dotted line. you can see that in the last 12 months of life, there is a slow increase in healthcare utilization, rising exponentially in the 5th month to the point of death. For advanced dementia, the greatest contributor to the healthcare utilization, as you can see in column B on the right side of my slide, is actually from length of stay. Our advanced dementia patients spend 2 months in the hospital in the last 1 year of their life, far exceeding that of cancer and other end-stage organ diseases. So what are the potential solutions that we can offer to our patients suffering with dementia, such that we are able to offer them evidence-based care, respectful of who they are, integrating our understanding of how dementia will evolve, and how we can meet their needs holistically using palliative care principles so that we can truly minimize their suffering and support their caregivers. So this was a recent review that was published in Palliative Medicine that examined different integrated models of dementia care throughout the world. How they did this study was that they took the European guideline for optimal palliative care for patients with dementia. They used a 9-domain framework from the EAPC, and they basically mapped all these different models of care to examine whether they actually honored patient-centeredness in their practice. Now, what does a patient-centered model of care actually look like? It means that it is respectful of the patient's needs based on an understanding of their illness. And in this case here, it would be dementia. That means that we are able to respond or shape-shift to their needs as their illness progresses, bearing in mind who they are, respecting their personhood, and honoring where they would be cared for, bringing in the correct resources. It is about helping the families understand the illness and to be able to help them to make the best decisions for their loved ones based on the evidence that is available. It is about continuing care not only within the hospital setting or within the tertiary setting, but also beyond the tertiary setting into the community in what we call a transmural of care in a collaborative manner. It is about bringing in all our team members. It is about upscaling and increasing all our capacity to be able to care for our patients, from the physician to the allied health colleague, to our complementary therapists, to our colleagues in the community as well. So it is all underpinned by an education of both palliative care and dementia care, and using symptom-specific tools so that we are able to pick up suffering, not only in the physical domain for our patients with dementia, but also in the psychological, spiritual, and social domains as well. Married into this is the timely intervention of palliative care, which we can do if we are able to prognosticate well, so that we are able to bring in resources in a timely manner and also have important discussions about who our patients are and what they would want together with their loved ones. We also need to have sound ethical understanding of the disease that is dementia so that we know when to offer treatment, when to withhold it, and when even to withdraw such treatment. So this study mapped the 9 principles against different models of care throughout the world. And I'd like now to actually apply a critical lens to one of these models that was featured in this study that just happened to be developed in Singapore. So this is Program Dignity, which was designed to be an integrated geriatric as well as palliative model of care to really look after patients suffering with dementia, originally just for patients who lived at home. But we extended this work into patients who were living in the nursing home as well. We wanted to design the study to be cognizant of who the patient was, to be cognizant of what the complications and needs would be in dementia care, and therefore be able to advise and support the patients in a much more holistic manner of a much more holistic model of care. So we really purposefully redesigned program dignity to evolve around the patient rather than the patient to move between the hospital and the home or the nursing home and the home. So program dignity was really designed to move around the patient. We acted as the mediators of the patient's care, communicating with our colleagues in the hospital if they needed to move back to the hospital for more interventions, or we communicated with our colleagues in the hospices, in the nursing home, or even in the community hospital, or even in their own homes. So we worked around the patient in order to effect the best outcome for them based on an understanding of who they were and where they would have liked to be cared for. The primary aim of Program Dignity was very simple. It was to increase palliative care access to patients suffering with dementia because there was a real gap and a real need in 2013. And interestingly, that gap still remains to this very day. We wanted to be able to identify symptoms in a much more intentional and a much more empowered manner because many of our patients cannot advocate for themselves and we need to stand in for them. So there are symptom-specific tools that I will share with you in a while. We wanted to have proactive plans of this care discussions. We didn't want to wait until they were very ill and be in a state of crisis in the hospital before we talked about where they would have wanted to be cared for and how they would have wanted to be cared for. So we wanted to do this very early on. We wanted to be able to support our caregivers and understand their needs, not only emotionally, but how we could respond to their needs in a very practical manner so that they could continue to look after their loved ones wherever that setting of care may have been. And last but not least, we wanted to be able to support program dignity beyond what was a funding period that was quite short. So we knew that we needed to prove that the model worked so that hopefully the Ministry of Health in Singapore would continue this care for our patients. So we used what we call a theory of change logic model. We knew that we needed to be very systematic and intentional about integrating workflows in the hospital and beyond the hospital so that these vulnerable patients could be identified and could actually have the correct resources assigned to them. So we developed these systematic workflows in the hospital as well as between the hospital and Program Dignity, the home care team. And even within Program Dignity itself, the home care team, we had very clear workflows for the care of our patients who were clinically well and for the patients who were clinically unwell. So this is actually the entirety of the workflow, and I need to, it is terribly busy. It is version 29.0. So even that when we were implementing it, we were changing it based on feedback from our colleagues, feedback from our patients, as well as feedback from Program Dignity. So it helped us to actually create a dynamic model of care that could be efficiently carried out so that maximum number of patients could receive the best care possible. So within the hospital itself, we use a very simple screening tool at the patient's bedside. This is the functional assessment staging of dementia, which at FAST 7 would imply the most advanced stage of dementia, where at 7A, our patients speak less than 6 words in a day, to 7B, where they cannot even vocalize at all. Now, this is a very distressing phrase that I see very often, non-communicative. But believe me, they communicate non-verbally, and we will see from these symptom scores, symptom tools in a while. So, and 7 goes all the way to 7F, where they are no longer they're no longer able to lift up their heads by themselves. So this is how advanced they are. And many of them are dependent in the bed and need complete help for their care. In addition to FAST 7, we have another criteria, another poor prognostic sign in the form of pneumonia in the past 1 year. So you see all these signs in the studies that I mentioned. Pneumonia in the past 1 year, a low serum albumin of less than 35 grams per liter, as well as the presence of an enteral tube or enteral feeding, which we know in itself increases the risk of aspiration and increases the risk of mortality. So patients who are identified in this manner are then referred on to the home care team, and we do this through a national agency. So we worked within Singapore in order to be able to ensure that there was a seamless flow, that no patients were lost in the process. So we use a computer system through the national agency in Singapore to move all these patients and flow them into the home care team with a very clear medical report as well as their needs. Within the home care team as well, you can see that there is a workflow for patients who are clinically well, and then another workflow for patients who are clinically unwell. And I'll share a little bit more in the next few slides. So what is so unique about Program Dignity? We were developed in 2014, and it was a very small team. It was just a team of a senior clinician, myself, a junior team member, a nurse, as well as a social worker. Now, many of you in the audience will already tell me there is no way, Allyn, that you can have a 24-hour, 7-day-a-week home care team running like this. And you're absolutely right. So what we did was that we looked at our community and we basically grafted ourselves. We got a palliative home care team, which was mainly cancer-centric to adopt us. So they adopted us, and what we did was that we brought in our dementia-specific screening tools. We taught the palliative home care team how to look after our patients suffering with dementia, and we offered to share the load of looking after their cancer patients. So my junior team learned how to look after their patients with cancer, and their team learned how to look after our patients with dementia. So there is a hidden curriculum to this program. What we did was that there was a mutual sharing of knowledge, a mutual sharing of skills, and an increase in confidence in terms of caring for patients with life-limiting disease. It has been more than 10 years since we integrated ourselves into Dover Park Home Care. And today, if you were to catch any of my team members, they are equally adept and confident in looking after patients with cancer as they are looking after the patients suffering with advanced dementia and other end-stage organ diseases. There is no differentiation in any of the team members. So there's this mutual sharing of information which really builds up a community of compassionate care, that it doesn't only exist in the tertiary hospital, which can sometimes be the most inhospitable place, but it goes into the community as well with this seamless sharing of communication and this seamless sharing of care so that all of us can learn to grow together. So some of the tools that we use, in fact, not some, all of the tools that we use are now used in my hospital in Tan Tock Seng as well as in the community. And every tool that I show you here can be easily deployed at the patient's bedside in the tertiary care setting, in the community hospital setting, and even in the patient's home, as has been demonstrated in this model of care. So for patients who are clinically well, at the first review and all subsequent reviews, we use the 5-category pain assessment in advanced dementia. It's a very simple tool where you can look at the patient's expression, their behavior to assess whether they are at pain, at rest, or on movement. So this is something that I often encourage my colleagues to do. So it gives us an idea of how comfortable our patients are in different settings of care. We also use a behavioral assessment tool called the Neuropsychiatric Inventory Questionnaire. It's a 12-item questionnaire that was validated by Professor Jeffrey Cummings in nursing homes and can be used in the home as well. We assess nutrition using the mini nutritional assessment. So we actually substitute height with calf circumference, so easily done for patients who are unfortunately wheelchair or bedbound. And we also use a quality of life assessment tool called the Qualit, which has also been validated in nursing homes as well. For patients who unfortunately have a prognosis of less than 1 month, so this is based on our clinician estimate of survival, then we suspend the tools that we use for clinically well patients and use instead the comfort assessment in dementia at the end of life, which is a comprehensive tool that looks at patients' physical suffering, spiritual well-being, and dying symptoms that need to be addressed. So this can be used when patients are terminally ill and may be dying. We do not forget the families as well. So at the first review and at subsequent reviews, if able, we do the Zarit burden interview. Now, at the start of this model, we use the 22-item ZBI, which I would advise you not to. It's far too extensive. You can just use the 12-item ZBI. Now, we examine for caregiver burden in order to be able to offer them not only emotional help, but practical help, such as getting a home sitter to sit for a few hours so that the caregiver can go out and attend to their self-care. We offer home respite services so that, again, the caregiver can go out and do the things that they need to do and come back refreshed in order to look after their loved ones. So these are practical aspects of health that is really needed from our patients with dementia. Last but not least, when our patients pass away, we actually check in on our caregivers, and we also make sure that we receive feedback to improve our care service even more. So this is what a interdisciplinary program dignity review looks like. This is in the home care setting, but it is very much like in the nursing home setting, except that we might not only have our caregivers, but we also have our very professional team of nurses, our nursing home nurses, and sometimes even the GPs join us as well. And these are opportunities for us to share each other's knowledge of who the patient is, where they are in terms of the illness, the complications that they have faced as well, so that we can really share how we can improve on care and really implement care changes should the anticipated complications arise. So at every review, we basically review the history. We try to determine if there are new changes in order to implement new care plans. We look at how they are being cared for and offer tips on how we can show more care in terms of how we non-verbally care for them. We know what are the symptoms and the complications that might arise. So we actually share with our teams, with our families, how can respond to it and how to contact us in a timely manner. Last but not least, as mentioned, we check in on our caregivers as well. So what are our patients' needs based on this model of care that we have determined so far? So based on this study, we have found that at least 49% of our patients suffer with pain to some degree. Patients on enteral feeding are perceived to experience a much greater degree of pain compared to patients who are on careful hand feeding. It is interesting to note that a large, or rather a significant proportion of our patients, more than 90% of our patients, are malnourished, although quite a significant number, more than 40%, are on enteral tube feeding. There was no difference in the nutrition scores between patients who were on feeding tubes versus patients who were carefully hand-fed. Last but not least, even in the advanced stages of dementia, more than 85% of our patients suffered neuropsychiatric challenges, and particularly in the area of eating, sleep, and apathy. The prognosis of our patients was generally very short, so very similar to the study that was conducted in the US. It was about 4 months in our patients as well. Now, the combination of pharmacological and non-pharmacological therapy that was implemented by Program D actually did show a positive benefit in the relief of pain, neuropsychiatric challenges, as well as caregiver distress in relation to neuropsychiatric challenges and quality of life. But I do need to qualify that patients who were on enteral feeding, that means that patients who were on feeding tubes, their quality of life did not improve in spite of everything that we did. We also examined what it meant to keep our patients comfortable at the end of their lives, and we found that the use of anticholinergics and at least one course of antibiotics seem to alleviate suffering, which is echoed by studies in the US as well. Interestingly enough, the use of opioids and more than one course of antibiotics was not associated with improved symptom burden, which is a very interesting outcome that we are continuing to look into. Essentially, factors that really ensured that our caregivers felt that care was satisfactory included the fact that their loved ones were comfortable at the end of their lives, and when we were able to honor medical preferences at the end of their loved one's life. What about the caregivers themselves? How did they feel? So we actually examined more than 377 family caregivers with the 22-item CBI. The median score suggested, which was 25, suggested that quite a significant proportion were at risk of anxiety and depression. A score of 24 suggests this. We found that younger caregivers were more likely to have a higher ZBI score. That means that they were more likely to have a greater burden of caregiving, and that their risk of depression were actually twice that of the older caregiver. Other variables that increased the caregiving burden included variables such as the lack of an informal paid help. That means that in Singapore, it's usually an additional helper. So if additional help was missing, that would increase their caregiving stress. When their loved ones suffered with neuropsychiatric challenges, this was also a factor that increased their stress as well. And when they were clinically unstable, certainly that stress level increased. However, the baseline caregiver burden did not influence their treatment decisions at the end of their lives. What about healthcare utilization with this model of care? So essentially, program dignity viewed the healthcare utilization costs in the positive manner, meaning that we examined patients who were in program dignity against a cohort of patients who had never received home care support in any form. Although our patients in program dignity were clinically more unwell, based on the Charlson Comorbidity Index, they actually had reduced acute healthcare utilization and overall a reduced cost. In simple language, what it meant for me to understand was that my patients were less likely to be admitted by one admission. So one admission less. And even if they were to stay in the hospital, their length of stay was reduced by 8 days. So this overall led to a reduction in healthcare utilization costs, which was at least 40% lower compared to patients who had never received home care support in any form. And the greatest impact was in the last 1 month of their lives. Now, it would not be surprising for all of you to learn that the longer that they were in program dignity, the greater the healthcare savings. We also noted in our patients that there were more plans of care discussions, there were more ACPs discussed, and that yes, we did achieve our primary aim that more patients with dementia had access to palliative care, but I'll tell you that this is not enough, and why in a while. So because of these positive findings, the Ministry of Health in Singapore realized that, you know what, this care could really benefit more patients. So they basically extended the funding for patients with dementia who wanted to spend their last days at home or in a nursing home from 6 months to 1 year. So they increased the funding for them, and they also allowed them to use their savings plan in an unlimited manner in recognition of the fact for their healthcare costs. I need to qualify for their healthcare costs in recognition of the fact that dementia is a terminal illness, and its complications will eventually lead to the demise of our patients. The program dignity criteria is now the national criteria for patients throughout Singapore to access home care services throughout the island. So it is now not only for patients from my hospital, this model has now extended to the whole of the country as well. And they can use this criteria in other hospitals in order to be able to refer their patients. So I used program dignity in this study in order to summarize what are the key points in a patient-centered model of care that we can ensure exists in order to develop more models of care. Now, they include the fact that the referral pathways should be simple and they should be easily delivered at the patient's bedside. The flow sheets that I showed you were terribly long, and they would not even have filled 3 slides. They were just so extensive. So I really had to truncate it down to as simple as possible so that it could be utilized. And if you are able to utilize your workflows more, it means that more patients can access this care. We need to be able to integrate the different symptom assessment tools for our patients, not only within the hospital. There needs to be better coordination of care within the hospital, but beyond the tertiary care hospitals into the communities as well, where many of our home care patients, where many of our patients with dementia want to continue to live in. How do we ensure that the models that we develop in Thailand, in Singapore, continue to be sustainable? Well, it means that we need to document what are the barriers and what are the facilitators to the development of these models. And we need to work dynamically to improve on it so that more patients can actually access this care wherever they are. We need to measure their outcomes from the patient's perspective, the caregivers, as well as the healthcare's perspective, so that we can really maintain these models of care beyond funding periods. Last but not least, it is about scaling each other up with regards to the awareness of the needs of patients with dementia and how palliative care can support them. It is about growing and being humble enough to grow alongside our patients as well as with our colleagues with different expertise. And it's about being able to then, examine these outcomes and to be able to share these outcomes so that we all grow together as an international community. Now, what happens if, let's say, you're just starting out with developing a model and you may not have much of those resources available? Are there other simpler models of care that you can first use in order to grow your service? Now, this is a randomized controlled trial conducted by Professor Greg Sachs, who is himself a geriatrician with palliative care interests as well. Now, what he did over a period of 2 years was to recruit patients with advanced dementia, and his nursing managers called the patients' caregivers every month to share non-pharmacological management techniques. Now, his primary aim was to see whether the advice from his nursing managers over the phone, mind you, and this was during the period of COVID, would actually change outcomes in terms of symptom scores with the symptom management at the end of life, which is very similar to the comfort assessment in the end of life tool, but this is for 3 months, as well as the neuropsychiatric challenges, as well as caregiver burden. Now, although they did not show any change in symptom scores at the end of 2 years, nor did they show any change in caregiver distress, what they did effect at the end of 2 years was an improvement in healthcare utilization. So this is a way that you can think about to start off your service first. So clearly, I hope that by now you will agree with me that our patients with dementia, although they cannot tell you in an articulate manner, that they do have needs that need to be addressed and can be addressed with an intentional, integrated manner. So if there is benefit to integrating palliative care, can more patients receive this care? So if you remember, my initial aim was to have more patients receive this care, but when we really dived into our data even more, we realized to our horror that more than 50% of our patients were referred in the last 30 days of their life. Now, when patients are referred to palliative care in the last 30 days of their life, Professor Shriving will teach you this is not palliative care, this is hospice care. So we need to get into our patients' care much earlier and not at the end of their lives. So much of that problem required us to confront our deficiencies as a healthcare community, and we realized that we were prognosticating far too late for our patients. So much so that we implement palliative care only in the last few days to last few hours of their lives. Now, many of us here will agree that advanced care planning or timely discussions require accurate or fairly accurate prognostication. We know that we cannot prognosticate completely accurately, but we need to do a better job so that we can discuss in a timely manner about the plans of care and get into our patients' care plans, resources that can continue to support them, not only within the hospital, but beyond the hospital as well. So we developed a prognostic model called the Prognostic Model in Advanced Dementia by examining more than 1,000 patients' case notes in our hospital. And we basically developed this 9-item prognostic tool that consists of variables that are very familiar to you. They include an increasing age that we discussed, the male gender, poor prognostic factors such as a pneumonia in the past 1 year, the presence of pressure ulcers, a high Charlson comorbidity index, meaning more medical problems, dependency, which would reflect fast staging, the presence of dysphagia or eating orders, and abnormal urea or albumin scores here. So albumin here is more an inflammatory marker than a nutritional marker. Based on a composite score, the ProMate model can actually identify correctly patients at least 76% of the time, their risk of deteriorating within 1 year. Now, it is very hard to apply this model at the patient's bedside. So what we've done is that we've actually implemented it as a predictive artificial intelligence tool in our medical records. So patients who are diagnosed to have fast 7C dementia are then actually risk stratified to receive either basic palliative care from the primary team, which includes advanced care plan or preferred plans of the care discussion, in addition to usual dementia care, or high-risk patients who receive palliative care referrals as well as resources in the community as well. So we want to prognosticate well in order to move beyond the hospital setting and offer basic palliative care to patients who are low risk and specialist palliative care to patients who are beyond lower risk or higher or moderate risk. And we want to move this into the community so that more patients can access the resources that are already available in the community. We hope that by doing this, we're able to shift the integration of palliative care into dementia care from the end of life into much earlier on, 12 months at least, so that more patients can avail of this very important and helpful care at an earlier phase of their disease trajectory. So I'd like to basically end off by reflecting on where specialist palliative care stands in dementia. Can I use it at all phases? And the answer is simply yes. We really want to get palliative care in when patients need it, and this is based on needs assessment when they have more symptoms, if they have a very rapidly progressive dementia, or they have other other needs beyond symptoms, such as increased hospital admissions, increased healthcare utilization, then certainly in this Delphi study, specialist palliative care should be involved. So I leave you with my last slide that summarizes how we as an integrated community, palliative care physicians, general medicine physicians, neurologists, general practitioners, internists, can work together, not only as physicians, but as an integrated, interdisciplinary community to bring in the evidence, to develop patient-centered models of care, to bring about the best outcomes for our patients. So thank you very much for your time, and I'll be happy to answer any questions later. Thank you.
Okay. Thank you very much, Dr. Allyn, for your very comprehensive presentation. So before we move on to the Q&A session, I would like to invite Dr. Khon to please provide a brief summary of Dr. Allyn's lecture in Thai. Thank you.
ก็เดี๋ยวจะพยายามสรุปให้เร็วภายใน5 นาทีนะครับ จะได้มีเวลาตอบคำถามนะครับอาจารย์พูดเร็วมากเนื้อหา60 สไลด์นะครับ ก็โอเคครับ ก็ในหัวข้อนี้ก็คือทำยังไงให้เราดูแลคนไข้ผู้สูงอายุได้ดีขึ้นนะครับ โดยอาจารย์เขาก็ได้มาพัฒนาโปรแกรมขึ้นนะครับ เรื่องของการดูแลผู้สูงอายุ อันแรกก็คือผู้สูงอายุเนี่ยมีจำนวนเยอะมากแล้วเพิ่มขึ้นเรื่อยๆนะครับแล้วคนอายุมากขึ้น อายุมากขึ้นก็ดิเมนเชียมากขึ้น แล้วก็การดูแลคนไข้ที่เป็นดิเมนเชียเนี่ยปัจจุบันเริ่มช้ามาก ข้อที่ต้องทำคือต้อง Early Integrate อย่างเร็วนะครับอาจารย์เขาเริ่มทำโปรแกรมดิเมนเชียตั้งแต่10 กว่าปีที่แล้ว สมัยนั้นคนยังดูแต่ cancer นะครับซึ่งดิเมนเชียเนี่ยเป็นโรคที่มันแย่มากตรงที่ว่าคนไข้เนี่ยเขาตายจากญาติตั้งแต่ก่อนที่คนไข้เขาตายจริงๆซะอีกเพราะคนไข้เขาไม่สามารถสื่อสารทำอะไรได้นะครับเพราะฉะนั้นเราถึงบอกว่าต้อง early integrate เข้าไปนะครับแล้วก็คนก็ใส่ใจดูแลเรื่องของดิเมนเชียน้อยนะครับทั้งที่เมื่อเทียบดิเมนเชียกับ cancer เนี่ยกลุ่มดิเมนเชียเนี่ยถูกทำหัตถการใส่ทิว CPR เยอะมากใส่ NG feed แล้วก็มีอีเวนต์ต่างๆระหว่างการรักษาในช่วง4 เดือนสุดท้ายเนี่ยเยอะมากนะครับสิ่งที่เป็นปัญหาก็คือเรื่องขององค์ความรู้การที่เราเห็นว่าเขาพูดไม่ได้เราก็เลยเกิดความละเลยนะครับทีมไม่มีความสนอกสนใจแล้วก็ระหว่างทีมไม่ได้มีการพูดคุยกันการดูแลคนไข้ดิเมนเชียเนี่ยมันต้องเป็นการดูแลไม่ใช่แค่เฉพาะในโรงพยาบาลต้องดูแลทั้งในโรงพยาบาลใน nursing home รวมถึงบ้านของเขาในช่วงปีสุดท้ายเขาอาจจะเข้าโรงพยาบาลบ่อยนะครับแล้วก็พอมาดูเรื่องของค่าใช้จ่ายปรากฏว่าคนไข้ดิเมนเชียเนี่ยนอนโรงพยาบาลเยอะมากแล้วก็6 เดือนสุดท้ายเนี่ยแอดมิดทีนะครับสิ่งที่อาจารย์เขาทำก็คืออาจารย์เขาได้เอาไกด์ไลน์ของยุโรปเนี่ยเอามาอินทิเกรตในโมเดลการดูแลผู้ป่วยของสิงคโปร์นะครับก็มีตั้งแต่เรื่องของการพยายามให้คนไข้เข้าถึงมากขึ้นนะครับแล้วก็ทำยังไงให้รู้จักตัวตนของเขาจะรู้ว่าเข้าไปดูแลเขายังไงนะครับเชื่อมโยงทั้งโรงพยาบาลชุมชนแล้วก็ผู้ดูแลทีมสหสาขาทั้งในโรงพยาบาลแล้วก็ในทุกๆเซตติ้งโรงพยาบาลบ้านชุมชนนะครับโปรแกรมของอาจารย์เขาเนี่ยชื่อว่าโปรแกรม Dignity นะครับหรือว่าเป็น Community ในไทยก็อาจจะใช้คำว่าอย่างสมศักดิ์ศรีนะครับก็เป็นการรวมกันทั้งระหว่างของผู้สูงอายุ Palliative Care นะครับแล้วก็อย่างที่แจ้งว่าดูแลตลอดทั้งในบ้าน Nursing Home แล้วก็โรงพยาบาลโดยมีทีมเนี่ยเป็นตัวกลางในการดูแลแล้วโปรแกรมนี้ทำอะไรบ้างนะครับเพิ่มการเข้าถึงการจัดการอาการวางแผนการดูแลล่วงหน้าแล้วก็ดูแล Caregiver ด้วยนะครับโดยอาจารย์เนี่ยเขาเริ่มตั้งแต่ว่าทำยังไงให้คนไข้เข้าถึงใช้สกรีนนิ่งง่ายๆว่าคนไข้อยู่ในfast state ที่ 7A หรือว่าพูดได้แค่6 คำต่อวันนะครับแล้วก็อาจจะมีไครทีเรียตามมาก็คือมีปอดติดเชื้ออัลบูมินน้อยกว่า 3.5 หรือใส่ NG ทิวและเพื่อไม่ให้คนไข้หลุดระหว่างทางอาจารย์ก็ใช้โปรแกรมคอมพิวเตอร์ซึ่งเป็นระดับประเทศของที่สิงคโปร์เพราะฉะนั้นโปรแกรมเนี้ยคนไข้ไม่ว่าจะเข้ามาอยู่ที่โรงพยาบาลหรืออยู่บ้านหรืออยู่จุดไหนทุกคนจะรู้ว่าเขาเข้าสู่โปรแกรมนะครับซึ่งในช่วงแรกมันก็ทำได้ยากเพราะว่ามีรีซอสน้อยนะครับโมเดลที่ทำได้ที่อาจารย์เขาทำคือต้องเชื่อมโยงนะครับอินทิเกรตเชื่อมโยงทั้งในเรื่องของการดูแลองค์ความรู้แล้วก็ทักษะต่างๆนะครับในขณะที่เราไปดูคนไข้เราก็ถือโอกาสสอน nursing home ไปด้วยว่าในเคสที่เป็น dementia จะดูแลยังไงนะครับการประเมินนะครับอาจารย์เขาก็ใส่เครื่องมือลงไปในโปรแกรมนี้เพื่อประเมินโดยประเมินทั้งคนไข้แล้วก็ครอบครัวประเมินทั้งในกลุ่มที่อาการคงที่แล้วก็ใกล้เสียชีวิตนะครับของคนไข้ครอบครัวก็ดู caregiver burden แล้วก็ดูหลังการสูญเสียด้วยนะครับแล้วก็มีทีมสาขาวิชาชีพนะครับต้องมีคือโปรแกรมค่อนข้างชัดเจนว่าอันไหนจะรีวิวทุก3 เดือนอันไหนจะทบทวนทุก6 เดือนอะไรต่างๆเพื่อให้การแคร์มันไปได้ตลอดทางโอเคนะครับแล้วก็เรื่องของอาการเนี่ยอาจารย์เขาบอกว่าคนไข้ที่เป็นดิเมนเชียเนี่ยอาการปวดเยอะมากถึง 50%คนที่ปรากฏว่าถูกใส่ NG เนี่ยปวดเยอะกว่าใส่ NG แล้วภาวะโภชนาการไม่ต่างนะครับแล้วก็พออาจารย์เข้ามาวัดดูนะครับคนไข้เนี่ยไม่ว่าจะใส่ NG ไม่ใส่ NG พยากรณ์เฉลี่ยอยู่กลางๆที่สักประมาณแค่4 เดือนนะครับการที่ใช้แอนตี้โคลินเจิกลด secretion แล้วก็การให้แอนติไบโอติกน้อยกว่าหรือเท่ากับ1 ครั้งนะครับในช่วงสุดท้ายเนี่ยครับจะช่วยให้คนไข้เนี่ยคอมฟอร์ตมากขึ้นช่วงสุดท้ายคือ2 วีคสุดท้ายแล้วให้คนไข้ตายได้จากไปได้อย่างคอมฟอร์ตแล้วสบายมากขึ้นในขณะเดียวกันการให้แอนติไบโอติกมากกว่า1 คอร์สนะครับถึงแม้ว่าจะให้โอปิออยด์ด้วยเนี่ยก็ยังสัมพันธ์กับการที่คนไข้เขาไม่ค่อยสุขสบายในช่วง2 อาทิตย์สุดท้ายสิ่งที่ทำให้ญาติพึงพอใจในช่วง2 อาทิตย์สุดท้ายคือคนไข้สุขสบายไม่กระสับกระส่ายแล้วก็ คนไข้ได้รับการดูแลตามที่คนไข้เคยสั่งเสียเอาไว้นะครับแล้วก็ญาติก็มีภาวะ depress เยอะนะครับแล้วก็อาจารย์เขาเอาโปรแกรมนี้ไป implement นะครับแล้วก็มีการเทียบระหว่างคนที่เข้าโปรแกรม Dignity กับคนที่ไม่ได้เข้าปรากฏกลุ่มที่เข้าโปรแกรม Dignity เนี่ยลดค่าใช้จ่ายนะครับแล้วก็คนไข้เนี่ยแม้ว่าเราจะเข้ามาดูแลเขาเร็วขึ้นก็ยังลดค่าใช้จ่ายลดการใช้ทรัพยากรในโรงพยาบาลต่างๆได้ดีกว่านะครับลดการนอนโรงพยาบาลไปได้ประมาณ8 วันนะครับลดการเข้าโรงพยาบาลลดเข้าห้องฉุกเฉินเพิ่มเรื่องของการพูดคุยเป้าหมายการรักษาเสร็จแล้วเนี่ยครับอาจารย์เขาก็มาพูดถึงอีกอันนึงก็คือเป็นอ่าขอโทษนะครับเอา key component ก่อนแล้วกันนะครับเยอะมากนะครับครับ key component อีกอันนึงปัจจัยสำคัญที่ทำให้ develop palliative care กับ elderly ได้ดีนะครับอันแรกก็คือต้องมีเส้นทางการเข้าสู่โปรแกรมที่ง่ายเพื่อให้คนไข้เข้าได้เยอะแล้วก็มีการประเมินตั้งแต่เบื้องต้นแล้วก็ต้องมีทีมสหสาขาวิชาชีพเข้ามาเชื่อมโยงทั้งในโรงพยาบาลนอกโรงพยาบาลนะครับเพื่อให้โปรแกรมมันยั่งยืนเนี่ยจะต้องมีเรื่องของการส่งเสริมองค์ความรู้ทักษะอย่างต่อเนื่องนะครับแล้วก็มีการวัดผลเพื่อสะท้อนกลับว่าทำไปแล้วดีหรือไม่ดีอย่างไรนะครับแม้ว่าโปรแกรมของอาจารย์ที่ทำเนี่ยจะดีมากนะครับก็ยังเห็นว่าคนไข้ประมาณ 50% ก็ยังเข้าในช่วง1 เดือนสุดท้ายก่อนที่จะเสียชีวิตซึ่งอาจารย์ก็บอกว่ามันก็ยังถือว่าช้านะครับสำหรับเรื่องของการพัฒนาคุณภาพนะครับปัญหาของอาจารย์ที่เขาพบก็คือว่าการเข้าถึงยังน้อยแล้วก็เรื่องขององค์ความรู้นะครับของทีมสุขภาพสิ่งที่ต้องทำก็คือทำให้คนเข้าใจว่าโรคนี้ก็เป็นโรคที่ต้องการการดูแลแบบประคับประคองการดูแลควรควบคู่ไปกับความต้องการของคนไข้นะครับแล้วก็ความค่านิยมต่างๆที่เขาต้องการนะครับแล้วก็พูดคุยเรื่องของแผนการดูแลล่วงหน้าในช่วงเวลาที่เหมาะสมและในปี 2023 นะครับมีเครื่องมืออันหนึ่งที่เขาผลิตออกมาชื่อว่าโปรเมดนะครับอันนี้ก็เป็นการทำนายเรื่องของการรอดชีพในผู้ป่วยที่เป็นสมองเสื่อมขั้นรุนแรงนะครับโดยถ้าหากมีไครทีเรียตามนี่คืออายุมากกว่า85เป็นชายมีปอดติดเชื้อเพรสเชอร์ซอชาวสั้นมากกว่า8นะครับคนไข้ติดเตียงนะครับกลืนลำบากแล้วก็อัลบูมินต่ำเนี่ยโอกาสที่จะเสียชีวิตใน1 ปีเนี่ยอยู่ที่ 0.76% นะครับอาจารย์เขาก็ได้เอาอันเนี้ยเข้ามาใช้ในโมเดลของการดูแลของอาจารย์เขาด้วยโดยคนไข้เขาเนี่ย1ก็คือเริ่มตั้งแต่สกรีนนิ่งใช่ไหมครับที่บอกว่าใช้ Fast Stage 7A นะครับเสร็จแล้วก็มาใช้ผ่านโปรแกรม ProMed นี้แล้วเขาก็มาดูว่าคนไข้เนี่ยเป็น High Risk หรือว่า Low Risk ถ้าเกิดเป็น High Risk ความเสี่ยงสูงก็จะเข้าสู่ Specialist Palliative Care แต่ถ้าเกิดเป็น Low Risk ก็จะเข้าสู่การดูแลทั่วไปบวกทำแผนการดูแลล่วงหน้านะครับซึ่งอันนี้ก็ implement ทั้งในโรงพยาบาลแล้วก็ในการดูแลเยี่ยมบ้านนะครับแล้วก็พูดถึงว่าบทบาทของ Palliative Specialist ก็ยังคงมีความจำเป็นอยู่ในเคสที่มีอาการไม่สุขสบายเยอะๆหรือปัญหาทางด้านจิตใจต่างๆนะครับสุดท้ายอาจารย์เขาก็เน้นย้ำว่าโปรแกรม Dignity เนี่ยมันจะต้องมีทีมของทีมของโปรแกรม Dignity นะครับอยู่เคียงข้างคนไข้กับครอบครัวไม่ว่าเขาจะเดินทางไปสู่เส้นทางของโรงพยาบาล Hospice บ้านหรือว่า Nursing Home ขอบคุณครับ
very much, Dr. Khon, for your translation. So we have one question for Dr. Allyn from Dr. Chintana. So the question is, dementia is a slowly progressive clinical syndrome. When is the optimal timing in initiating an advanced care plan in patients with mild to moderate dementia to find the right balance between the patient's decision-making capacity and refusal to talk about end of life, especially in Asian cultures?
Thank you very much for that question. And thank you, Dr. Khon, for translating for me. And thank you for this brilliant question, Dr. Jintana. I think I struggle with that in my practice. It's a very real problem. And what I found is that you need to build that rapport with your patients and caregivers so that they can trust you enough to actually conduct this discussion about, about their care in a very sensitive manner the plans of care discussion is not just about discussion of care, it's also about a discussion of their understanding about their illness, because their care plans developed based on an understanding of their illness. So their understanding of their illness is somewhat fragmented or quite poor. You can imagine that the care plans might be not quite appropriate to their care, to their trajectory. So for patients with mild and moderate dementia, I think that what we try to do is to teach them about the illness, to basically anticipate what is to come next and how we can actually preserve their function, their cognitive abilities as far as possible. When they continue to progress or deteriorate, then we are there with them. We've hopefully anticipated it, and we are ready to be able to bring in other rehabilitative resources that can continue to try to maintain and slow down that deterioration. So at all these points of time, you're actually having active discussions about about their understanding of their illness and their care plans. So it's at these points that I bring in plans of care discussions, not only about the issue of dementia, but there are other comorbidities as well, because we know many of our patients are quite frail. So that when they progress, they would have heard from us already to a certain extent what it might look like. So hopefully they're not so frightened. These discussions are very hard for them. Every time I try to initiate it, they always tell me, oh, later, Allyn, later. Let's talk about it the next time I see you. And they always hope that I will forget about it. But I really think it's something that I hope I talk about it in such a way that they see it as part of their, it's not just planning of their care, but me being a good physician for them, so that I know who they are and I can advocate for them. I can bring in what I know it helps and does not help them, so that we are able to guide the patients and guide families. So really initiate advanced care planning as early as possible. I don't signpost it and say, okay, I'm going to do an ACP now. Rather, I make it as part of the, tell me what you think about the fact that your father is now no longer able to speak as much as he used to. What do you think might be happening? And I bring in all these other discussions around plans of care, around normal dialogues, or what I perceive to be dialogues about their care. Yeah, so I hope this helps.
Okay, thank you very much, Dr. Allyn. We have one more question. Yes? Okay, I'm so sorry. So we need to translate your answer first. So please, Dr. Khon.
ครับก็ถามว่าเราจะคุยเรื่องแผนการดูแลล่วงหน้ากับผู้ป่วยที่สูงอายุในที่เขาเริ่มมีภาวะสมองเสื่อมในขั้นต้นกับขั้นกลางยังไงดีนะครับโดยเฉพาะในบริบทของเอเชียนะครับอาจารย์เขาบอกว่าเรื่องนี้อาจารย์เขาก็เจอเพิ่มขึ้นเรื่อยๆแล้วมันก็ยากนะครับสิ่งที่อาจารย์เขาแนะนำก็คือว่าเราน่าจะคุยให้เร็วที่สุดเท่าที่จะเป็นไปได้เราอาจจะไม่ได้ไปคุยเรื่องของการทำอะไรในช่วงวาระสุดท้ายแต่เราคุยให้เขารู้ก่อนทำให้เขาเข้าใจก่อนว่าความเจ็บป่วยเขาเป็นยังไงนะครับเพราะว่าในคนไข้คนสูงอายุเขาจะมีทั้งโรคร่วมต่างๆมากมายแล้วก็เรื่องโรคสมองเสื่อมของเขานะครับก็ทำให้เขาเข้าใจสถานการณ์ก่อนแล้วก็ค่อยๆพูดว่าต่อไปมันอาจจะเกิดอะไรขึ้นซึ่งพอจะคุยแต่ถึง ACP คือบางทีคนไข้ก็ยังไม่อยากคุยแล้วก็เลื่อนไปแต่อย่างน้อยเนี่ยการที่เราได้คุยตั้งแต่ต้นเนี่ยทำให้เรารู้จักเข้าใจตัวตนความต้องการคุณค่าเป้าหมายต่างๆของเขาซึ่งในอนาคตถึงแม้ว่าเขาอาจจะเป็นดิเมนเชียที่มากขึ้นแล้วจำได้เราก็ยังเอาข้อมูลเหล่านี้ไปคุยกับญาติหรือใช้กระตุ้นในการคุยกับเขาเพื่อทำACP ในตอนที่เขาความสามารถในการรับรู้ถดถอยไปได้
Okay, thank you very much, Dr. Khon, for your translation. Now we have one more question for Dr. Allyn. This question in Thai, so I'm going to read the Thai question first and then translate. ขณะนี้โรงพยาบาลส่วนใหญ่ตั้งตัวชี้วัดเรื่องลดอัตราตายในแต่ละกลุ่มโรคทำให้ผู้ป่วยได้รับการรักษาจนไม่สามารถไปต่อได้ถึงจะส่งปรึกษาที Palliative ทำให้เข้าไปดูแลคนไข้ได้ขณะที่เข้าสู่วาระท้ายอาจารย์มีคำแนะนำอย่างไรในกรณีนี้ So this question is basically asking about the general situation in hospitals where the mortality rate is one of the key indicators of the performance of that hospital. So the hospital administrators might have a propensity to kind of treat or have the physicians treat their patients to the very end to do everything to prevent to prolong their life for as long as possible. So in this case, so if the so how would the palliative team deal with situations like this?
Thank you for that question. I think that place of death is increasingly a quality indicator. And what we're trying to do is to ensure that our patients with chronic diseases do not die in the hospital, at least do not die in the hospital in an undignified manner. So I think that we are increasingly trying to focus not so much on we do need to focus on length of stay. We need to make sure that that length of stay has meaning to it, but we also need to make sure that that stay in the hospital is punctuated by good care, if not throughout the timeline. So we really need to also build in other indices of good care, such as were the physical symptoms addressed and how was it addressed? What were the tools that were used? How do you know that the patients are better? What were the psychological signs or symptoms that you helped the patient with? How did the caregivers feel that this care helped them? What were the other types of services that were brought in to support that dying in the hospital? So I think we need to shift focus on improving care at every health site, including in the hospital. So even in the hospital, if that has to be where the patient has to, is dying, then we need to make sure that the patient is comfortable in all these aspects and focus the hospital on such a compassion of care. I think that when I was at the opening ceremony as well, I was extremely touched to hear that the focus is really on how we can improve care for these patients, which is the right focus, and which is really what we should be doing, not about, how fast I can get the patient out, what is the length of stay, what is the number of admissions, but really in that stay, if that is the last stay for the patient, has that been a good stay? I hope I answered the question.
Okay, thank you. Would Dr. Thakor like to provide a translation?
ครับอาจารย์เขาบอกว่าเราอาจจะไม่ได้โฟกัสที่จำนวนการมีชีวิตอยู่หรือว่าตัวเลขต่างๆมากนะครับแต่เราน่าจะต้องกลับมาถอยหลังกลับมาแล้วมาโฟกัสว่าเราทำยังไงให้คนไข้ได้รับการดูแลอย่างดีคนไข้เขาไม่ได้จำเป็นที่ต้องเสียชีวิตในโรงพยาบาลไปเสียชีวิตที่บ้านหรือถ้าเขาจำเป็นต้องเสียในโรงพยาบาลเขาก็ได้เสียชีวิตในโรงพยาบาลอย่างสมศักดิ์ศรีมีคุณภาพชีวิตที่ดีได้รับการคัดกรองได้รับการจัดการอาการที่ดีไปอย่างสุขสบายสิ่งที่อาจารย์เขาบอกว่าเวลาโรงพยาบาลประชุมกันหรืออะไรต่างๆหรือว่าเรามักจะคุยกันว่าทำยังไงเราจะดูแลคนไข้ได้ดีขึ้นมากกว่าเราจะมาคุยกันว่าตัวเลขตัวนั้นมันมากหรือน้อยครับก็ต้องถอยกลับมามองว่าเราดูคนไข้เป็นศูนย์กลาง
Thank you very much, Dr. Thakor. And thank you again, Associate Professor Dr. Allyn for your very moving and inspiring presentation. Please give another round of applause to Dr. Allyn.